is the most vulnerable organ. 5% of all trauma admission is of liver injury. Most common organ injured in penetrating abdominal trauma. Penetrating abdominal trauma, it is the most common organ injured, and in blunt abdominal trauma, it is the second most common organ injured, because in blunt trauma, the spleen is the most common injured organ. There are two types of injury. It can be penetrating or it can be blunt. The operation which is required in that injury, both are different. In the penetrating injury, there should be surgical intervention, while in blunt trauma, it should be conservative intervention. In penetrating intervention, we can use after laparotomy with rooftop incision. Rooftop incision is necessary to assess the laceration, how much amount of laceration is there. Then the clot and the blood should be removed from the path. Then in liver injury, the control of bleeding is must. So the superior hepatic and inferior vena cava control is required. Liver wound is sutured using specialized needle, with vitriol using cooperating suture. Okay, liver wound should be sutured using specialized needle, and vitriol is the substance. And what is cooperating suture? If these are parallel sutures in the liver, so the perpendicular to it, the suture is taken. It is called the cooperating sutures. Then after taking the suture, the gel form or surgical is placed over it. Then in the penetrating injury, we should, after all this we should do adequate amount of blood transfusion, fresh frozen plasma transfusion, post-operative BT, CT is all measured. Antibiotic coverage with third generation cephalosporin is must. Blunt trauma, conservative intervention. First of all, it is assessed by CT scan. Here it is assessed by the laparotomy rooftop incision. Laceration is assessed, and here it is assessed by CT scan. Commonly used conservative intervention is the PACS. We put the PACS between the diaphragm and liver in blunt trauma injury up to 48 to 72 hours, and after it we will take these PACS outside. If it is very severe blunt trauma, then we go for the surgical intervention. If there is progressive deterioration and bleeding, and grade 5 liver injury is there according to CT scan, associated bowel injury is there, we can go for the surgical intervention. Pallor, hypotension, tachycardia, sweatings, these all are shock symptoms. Then distension of abdomen is there because of the liver injury. Oliguria means less amount of urine. Hemoperitoneum, rupture of right lobe is more than left lobe. Because of streamline effect, the rupture of the right lobe is more than left lobe. Biliary peritonitis is there. If bile leak from the injury side, the bile will in the peritoneum and it is caused biliary peritonitis. Clinical features: shock, distension of abdomen, oliguria, hemoperitoneum or biliary peritonitis. What are the investigation we go for? The first, this is common in many injuries. The first is chest X-ray, ultrasound of abdomen, CT scan of chest. It is most common investigation in all type of injury. Then we can go for the hemoglobin and blood group. We go for blood group because it needs massive transfusion in the blood injury. So if we know the blood group of the person or patient, we can use that blood for transfusion. Then the special investigation, it is FAST, which full form is focus assessment with sonography for trauma. Focus assessment with sonography for trauma. And the other one is DPL, means diagnostic peritoneal lavage. Diagnostic peritoneal lavage, if positive DPL is there, greater than 10 millimeter of blood loss and greater than 1 lakh cubic mm RBC or greater than 500 WBC are there. We can go for Thromboelastography, TEG, thromboelastography. Thromboelastography is dynamic form of assessing coagulation status of table. Okay. Arterio, we can go for arteriography, arterial blood gas analysis. We can. This is the most common. This is the special intervention we can get, and this is from our common sense. We go for this blood group and all. Okay. Now the CT scan and grades. So, subcapsular hematoma, intraparenchymal expansion, and capsular laceration. Subcapsular hematoma is greater than less than 10%. This is grade 1, and in grade 1 there is no parenchymal expansion, and the depth is less than 1 centimeter in capsular laceration. In the grade 2 there is 10 to 50 subcapsular hematoma, and get less than 10 centimeter diameter of parenchymal expansion, and depth is 1 to 3 centimeter. In grade 3 there is greater than 50% subcapsular hematoma, and greater than 10 centimeter diameter intraparenchymal expansion, and depth is greater than 3. And in the 4th category, 5th category, 6th category, parenchymal disruption 25 to 75%, and 1 to 3 coronate segment are involved. In 5th, parenchymal disruption greater than 75% and greater than 3 coronate segment are involved, and major hepatic veins are injured. In the 6th, hepatic avulsion is there. So these are the classification according to CT scan grades. Okay. In treatment part, first initial resuscitation is that. In resuscitation, we go for airway, breathing and circulation checking first. Then coming for the general measures, IV fluids and fresh frozen plasma can be given. Then bladder catheterization is there, because we know that in the clinical features there is oliguria. So that's why the bladder catheterization is there to measure the amount of the urine. Then the proconvertin, which is the factor 7 of coagulating factor. It is very effective, and 0.6 milligram per ml to 4.8 milligram per ml can be given. It is very expensive, but it is very effective proconverting factor. Okay, these are all the general measures. We must do it that general measure. Then we go for the initial conservative non-operative management. Non-operative management is there, which is more common in the blunt trauma. Okay, in which the patient this initial conservative non-operative management is there. The first is non-progressive liver injuries, in which hemodynamically stable हो सकते हैं. फिर lower grade 1 to 3 lower injury, low grade means this 1 to 3 categories patients. Then normal mental status, the need of less than 2 units of transfusion. These patients go for CT scan follow up. First CT scan and then follow up the CT scan. Then blood transfusion and prevention of sepsis. Then liver function test and prothrombin time is needed. In non-operative management, first we go for the angiographic embolization, which success rate is very high. Then ICU management 2 to 5 days. Patient rest for 3 months. If condition worsen from this level, we can go for the laparotomy. The intervention radiological measures, angioembolization can be taken in pseudoaneurysm, and the angioembolization complication is necrosis. So the care should be taken in this angioembolization. We now for the specific treatment. There are 3 types of treatment. The first is general measures are taken, then initial conservative non-operative management, and then the specific treatment. In specific treatment, there are 3 phases. First, control the bleeding, means pay closure, anything which control the bleeding, that measures should be taken first. Then resuscitation and metabolically managed. Temperature, PT, acidosis all should be managed. Then the third step is definitive procedure, resection or debridement or suture, it can be done. Then the specific treatment. Push. The first full push by direct compression. We can use plugging the deep track injuries using the silicone tube. The other one is Pringle maneuver to control the bleeding. Then pack. Liver wound is directly packed with mop. And if there is large injury, large bucket handle abdominal incision in laparotomy or thoracoabdominal incision should be there. If there is a small liver tear, vicryl or PDS mattress, suture with placing of gel foam. Gel foam is for control of bleeding. We can control the bleeding with Pringle maneuver or bulldog clamp, or the wrap with the mesh, the liver, which is called mesh hepatotherapy. And tractotomy. Though the liver parenchyma is soft and friable, liver is very, very difficult to suture because it is very soft and friable. So the ligation of bleeding vessels individually on cut surface is called tractotomy. Tractotomy is because as vessels are supported with fibrous adventitia. Liver parenchyma is soft and friable, but the vessels are supported with fibrous adventitia. If we ligate that that suture with the fibrous adventitia, we can hold well on these vessels, which is called tractotomy, ligation of bleeding vessel individually on cut surface. Then if there is deep injury, we can go for the segmental resection. If we segment the resection is there, regeneration of liver during the 4 to 6 months. On the resection, regeneration of liver take 4 to 6 months. 80% of liver resected without compromising the function. We can resect 80% of liver without compromising the function. If IVC injury is there, which is very difficult, we should do veno-venous bypass is made superior vena cava to femoral. Veno-venous bypass, superior vena cava to femoral. This is inferior vena cava is bypassed. And then first bypass the inferior vena cava, then repair that inferior vena cava injuries. And this is the artificial bypass in veno-venous superior vena cava to femoral. Then if liver tear is there, first suture, the suture of liver is with coarse nets of aluminum needle. And post-operative management, ventilator support and other measures should be there. The push, plug, Pringle maneuver, pack, then laparotomy for large incisions, small liver tear, vicryl or PDS mattress, then tractotomy, then deep injuries, then IVC injuries, then for liver tear, and then post-operative. The management. The all-over management in a glance. So the first is control the hemorrhage by packing, tractography, tractotomy, mesh, segmentotomy, transfusion. Control the hemorrhage first. Then management of metabolic disturbance, prevention of acidosis, disseminated intravascular coagulation, fast frozen plasma, platelets for management of metabolic disturbance. Then monitoring with repeated ultrasonography, CT scan, liver function test, prothrombin time. Then prevention of sepsis with antibiotic or irrigation with saline. Then identify and manage the complication. If portohepatic injury is there, it is very life-threatening, but it is rare. It's mainly occur in penetrating trauma. If portohepatic injury is there, portal vein should be sutured and common bile duct, a half circumference suture with over a T tube. Common bile duct should be sutured over T tube, half circumference. The complication is sequel of injury. The first is shock and hemorrhage, then liver abscess or septicemia, liver and intra-abdominal subphrenic abscess also complication is there, bile leak, bile peritonitis, disseminated intravascular coagulation and complication of blood transfusion, then electrolyte imbalance, respiratory complications, liver failure and late obstructive jaundice. Shock and hemorrhage, liver abscess, bile peritonitis, disseminated intravascular coagulation, electrolyte imbalance, respiratory complications, liver failure and late obstructive jaundice.